Welcome to our second patient education webinar. In case you missed it, in our first video, we talked about the importance of screening mammograms, and we took you through a visit so you would know what to expect at your own appointment. For more information on this and other webinars in our series, you can scan the QR code or click the button right there on your screen. Today, we're discussing breast cancer risk and breast density. I recently spoke to some radiologists and breast surgeons around the country and asked them what it means to be at a higher risk for breast cancer and what exactly is dense breast tissue. They answered these questions and more, and we're so glad that you've joined the conversation.
Hi, I'm Dr. Kang. I'm an interventional mammographer for a private practice group in Columbus, Ohio.
So Dr. King, I've heard a lot of women say, well, I don't have a family history of breast cancer, so I don't feel the need to get the screening. Can you talk a little bit about the statistics of how likely it is for somebody without a family history to present with breast cancer?
Breast cancer is one of the leading cancers for women in the United States. About 1 in 8 women will get breast cancer during their lifetime. And of those 1 in 8 women, the majority do not actually have a family history. That is one of the biggest reasons why we want everyone to be screened, not just people with a family history, not just people with a genetic predisposition to having breast cancer, but really just every single person that can be screened needs to be screened.
I'm Christine Ormsby. I'm currently practicing in Festus, Missouri, which is just outside St. Louis. I kind of rotate from site to site.
Dr. Ormsby, many facilities are starting to incorporate high-risk assessment in their facility workflow for screening patients typically. So can you talk about what a risk assessment is? What are we looking for? What kind of data are we getting from that? And then what do we do with it?
So a risk assessment for patients looks at multiple things. We're trying to gauge a patient's overall lifetime risk for developing breast cancer. Every patient is at some degree of risk for developing breast cancer just by being a female, but we want to know, are they average risk or are they high risk? The risk assessments take into multiple factors, and we're looking at overall their unopposed estrogen. So we're looking at several things. We're looking at height, weight, looking at family members, specifically first degree family members, but we do look at some of the family members down the line that may have had breast cancer or ovarian cancer. We look at things like when they started their menstrual cycle, did they have children? And if so, when did they have their first child? We look at all these things because we want to know how much estrogen they were exposed to, and also did they have any hormone replacement therapy. If a woman has a lifetime risk of developing breast cancer of more than 20%, she's considered high risk for developing breast cancer. That does not mean that she's going to, but it does mean we need to be a little bit more diligent about screening, and we need to do, in addition to our yearly mammogram, nothing will replace that mammogram, but we need to do a high-risk screening MRI in addition to that mammogram.
Can you talk a little bit about what different type of lifestyle choices that we can control and its impact to somebody's breast cancer risk?
So as you stated, there's many things we can control, many things we can't. Generally speaking, a woman just trying to have an overall healthier lifestyle is something that she can control. Not smoking is one of the most important things because smoking is overall just something that increases our risk of many, many cancers, and that includes breast cancer. Alcohol can increase our risk of cancer as well. Having a healthy body mass index, having a healthy body weight is something that can reduce our risk of cancer. And it also has been shown that if we were to develop breast cancer, we have better outcomes as well. There have also been some studies that have been shown that if we can reduce our lifetime stress, which if you can show us how, that would be great, but something that if we can reduce our stress, that helps us have better outcomes also.
Hi, my name is Barry Rosen. I'm a breast cancer surgeon in practice in the northwest suburbs of Chicago. And it is a pleasure for me to participate in any program that can help educate our patient population about the latest and greatest innovations available for breast cancer screening, diagnosis, treatment, and prevention.
So, Dr. Rosen, can you talk to us about what it means to have dense breast tissue or not? What makes up dense breast tissue? I know women are getting these results in their letters when they have their mammograms. So can you just explain to us what that means?
Breast density is not something that you can determine by physical examination. Breast density is best assessed by simply looking at a mammogram. And what the radiologist is doing is they're looking at the ratio of dense tissue to fatty replaced tissue. And what we currently do is we try to categorize women into one of 4 density categories, A, B, C, or D. And roughly half of all women in the United States have dense breast tissue, which would be categorized as C or D. And category C is called heterogeneously dense. Category D is extremely dense. The importance of breast density is twofold. First of all, if you have dense breasts, it may mask a cancer. So that if a woman with a breast cancer goes and gets a mammogram and they have dense breast tissue, there's up to a 25% chance that we're not going to see that cancer because it's going to be hidden behind dense breast tissue. So that's the first critical point about dense breast tissue. It masks cancers. The second critical issue, which I don't think is appreciated by as many people, is the fact that breast density is an independent risk factor for breast cancer. So a woman who has category C dense breast tissue may have a 1.5 to 2 times risk of breast cancer higher than the average woman. Now, when you get into extremely dense breast tissue, category D, they can have a 4 to 6-fold increased risk for breast cancer as compared to the population at large. So that's real and that's significant. So it's a cliche, but it's very true. Every woman should know their density. Now, category C, heterogeneously dense, 40% of all women are in that category. That is not a unique situation. Category D, extremely dense, that is. Only about 10% of women have category D dense breast tissue. So it's very critical to know your density and very critical to understand that it masks cancers and it does put you at a higher risk for breast cancer.
Dr. Rosen, a woman finds out she has either heterogeneously dense or extremely dense breast tissue. So what are her next steps? What can she do?
If you have dense breast tissue, what that tells us is that mammograms alone are not enough for screening. You have to supplement your imaging with a test beyond the mammogram, not to replace the mammogram, supplement. And there are a lot of options out there to supplement mammograms for dense breast tissue. There's screening ultrasound, there's contrast enhanced mammography, there's molecular breast imaging or MBI, or there is MRI. All of those are supplemental images that can overcome the inherent obstacle of seeing through dense breast tissue.
Hello, my name is Dr. Kimberly C. Hutcherson. I'm board certified, fellowship trained diagnostic radiologist specializing in breast imaging. I am the medical director of breast imaging at Northside Hospital Gwinnett in Lawrenceville, Georgia, and Northside Hospital Duluth in Duluth, Georgia. So patients should be aware of the breast density and know that for patients that have dense breast tissue, the mammogram interpretation may be limited. Breast density is a measure that we use as a radiologist to describe the amount of glandular tissue within a woman's breast tissue. There are 4 main types. You have dense breast, or we categorize you as having dense breast if you have more of this glandular tissue in relation to their fatty tissue. The reason why this is important is because the interpretation of mammograms can be limited due to the amount of the glandular tissue that you have. The dense breast tissue can actually obscure or hide or mask a cancer and not allowing us to detect these changes, but also can mimic or look like a breast cancer, and that can result in what we call a false positive, where we may see an area of concern, call the patient back for additional mammogram images and possible ultrasound, and ultimately it end up representing normal tissue. Now, this is a good thing that there's not an abnormality there. However, it has resulted in increased anxiety for that patient because they're thinking I might have breast cancer. There's also associated increased cost having additional mammogram and ultrasound images, and maybe sometimes even a biopsy. So I think it's important that the patients are aware that they have dense breasts, because mainly it will limit the interpretation of the mammogram. one of the advantages that we have now with mammogram is what we call 3D mammography, or digital breast tomosynthesis. And the advantage of that technology is it's going to help us out with some of those limited interpretations that we had with our 2D mammograms. 3D mammography, or digital breast tomosynthesis, is a technology that requires a series of low-dose x-rays and kind of an arc over the breast. The computer then generates those images into 1 millimeter slice thicknesses. So now I'm able to view the breast in several layers instead of just one 2D image. This allows us to remove the overlying tissue that may have been hiding or masking a cancer, so we're able to see it more clearly, but it also will eliminate some of those false positives, those things that we thought that may have been a cancer or an area of concern, and then in turn it represents normal tissue. So I do encourage women to, of all breast densities, but especially those that have dense breast tissue, to request a 3D mammogram or digital breast tomosynthesis for their mammogram imaging.
Hi, my name is Dr. Nicole Nelson. I am the medical director at the Women's Wellness Center at Mercy Health St. Rita's in Lima, Ohio. If you are at high risk of developing breast cancer, based on the American Cancer Society guidelines, if that risk is greater than 20% over the course of their lifetime, they should consider yearly screening breast MRIs. If you get your mammogram in January, you'll get your breast MRI in July, and get your mammogram in January, get your breast MRI. So every 6 months, we're screening those individuals. So the bottom line is everyone just has to continue to get their yearly screening mammograms, and that's your best tool. Another way to reduce risk for all cancers, whether you have extremely dense breasts or fatty breasts, but particularly those women with extremely dense breasts, it's the things that us physicians are always telling you, right? Reduce stress, healthy lifestyle, moderate or reduce your alcohol consumption. It doesn't have to be zero. Certainly don't have excessive alcohol use. Quit smoking, exercise, and just really try to embrace those factors that contribute to a healthy lifestyle.
So, Dr. Rosen, when do they know that they maybe need to be under the care of a breast surgeon versus maybe just their PCP or their OB-GYN? What advice do you have for women who are asking themselves, should I really be talking to a breast surgeon?
I think most people agree that if you have a 20% or higher lifetime risk for breast cancer, that would put you into the category of high risk. And if you're a high risk patient, I believe that you belong in either a high risk clinic, which more and more hospitals are providing these days, but probably at most 10% of all hospitals have a formal high risk clinic. If your hospital doesn't have a high risk clinic, then yes, I would definitely see a breast surgeon to establish a relationship and to provide high risk surveillance.
My name is Dr. Beth Dupree. I am a breast cancer surgeon and I work currently in Sedona, Arizona. I've been in practice for over 30 years where I have chosen to limit my practice to the diseases of the breast. There are many what I call myths and misconceptions in breast cancer care that need to be dispelled because myths are just that, they are not truths. So myth number one, women that are under the age of 30 don't get breast cancer. That is absolutely false. Luckily, I have many patients who are alive and well, having been diagnosed with breast cancer under the age of 30. And they're alive and well because when they felt a lump in their breast, even if their doctor said, oh, it's a fibroadenoma, or oh, it's going to be benign because you're young and you don't have any family history, they said, go see a breast surgeon, get it evaluated. Don't take no for an answer. You need to know what it is. Another big myth, silicone breast implants. There's been a lot of information propagated on the internet that the implants cause breast cancer, but there has been no study to date to show that silicone implants cause breast cancer. Another myth is that only women get breast cancer. And while women are at much higher risk than men for getting breast cancer, men do get breast cancer as well. And we see this in particular for people who have hereditary predisposition. So if a man has many relatives with breast and or ovarian cancer, and even more so if a man learns of a family member who did have genetic testing and had a mutation, they need to be tested
because they are at risk for breast cancer. Thankfully, I'm not hearing this myth as often as I used to, but every once in a while, I still will hear someone who's concerned that by operating, that the air will contact the cancer and the cancer will spread. And, thankfully, I think that myth is really debunked in most people's minds these days, but that's absolutely untrue. And likewise, some women are understandably concerned that when we talk about a biopsy and putting a needle into cancer, some women ask a very insightful question. Well, if it is a cancer and you put a needle in it, is that going to cause the cancer to spread? Thankfully, we have thousands and thousands and thousands of examples over the past 30 years that have shown us that biopsying a cancer by a core needle will not contribute to the spread of a cancer. Another myth that I hear often, if I have a lump in my breast, it means that it's cancer. And well, of course, if a woman feels a lump in their breast, they definitely should seek out the attention of a physician. Typically, the best place to start is with their primary care doctor or their OB-GYN. But an overwhelming majority of the lumps that we feel aren't cancerous. In fact, the breast by its very nature is a lumpy, bumpy organ. I've been doing this for over 25 years. And without my trusted ultrasound in my hand, I can be fooled very, very often by physical examination alone. And I don't expect my patients by self-examination to be able to distinguish a lump that counts from one that doesn't. So if you have a lump, go see your doctor, but be reassured that far more often than not, it is not cancerous.
Thank you for joining us today as we explore breast cancer risk and dense breast tissue. We hope you found the information valuable. We do have downloadable resources for you if you'd like more information. Join us next time as we dive into diagnostic imaging, second look mammograms, and ultrasounds. If you're ever called back from your screening mammogram, we'll walk you through the process so you will know what to expect for your own visit. You can scan the QR code on your screen or click the button for more information to see the rest of our webinar series. As always, we wish you good health. See you next time.